Hello, my name is Madina Sukhanova, and I'm board certified clinical cytogeneticist and molecular geneticist, and I'm going to talk about chromosomal aneuploidy in meningioma. I'll show you the data for two distinct subgroups, meningiomas with whole chromosomal gains and meningiomas with whole chromosomal losses. I have nothing to disclose. So this is a page from World Health Organization classification of meningioma, which historically relied and subclassified meningiomas into 15 morphological subtypes. And although meningioma is a very common intracranial tumor in adults, it's definitely understudied. And although many tumors are benign and curable by surgical resection, at the same time, almost a third still recur. So predicting and recognizing those tumors in need of treatment is very important. And even with somewhat limited gradient classification, you can see that meningioma has a very drastically different outcomes. The current grading criteria heavily rely on histopathological markers. And the main one is the counting of mitotic figures with a very wide range of less than 4 for grade 1, between 4 and 20 for grade 2 meningioma, and over 20 for grade 3 meningiomas. With only 2 molecular alterations so far recognized as grade 3 markers, and that's TERT promoter mutation and homozygous deletion of CDKN2A and B at chromosome 9p. And in addition to World Health Organization, the impact guidelines added recently deletion of 1p also as a high-risk marker. You can clearly see that this current grading system is far from perfect with a very high recurrence rate, and that indicates that advanced molecular characterization is needed. Predicting of tumors in need of treatment based off MRI is impossible, but even after resection, the counting of mitotic figures is very visual and subjective. It's not clear what to do with additional atypical histopathological subtypes outside of recognized 15 and intratumor heterogeneity. And a big progress was achieved with DNA methylation classification of meningiomas. DNA methylation classifiers predict recurrence much better than histopathological, but methylation also not universally available. So there was a significant effort in counting and trying to group copy number, chromosomal gains and losses in attempt to build a more integrated grading system for meningioma. What we looked at in this study, we looked at meningioma cases with whole chromosomal gains and whole chromosomal losses. Gains of chromosomes over a normal count of 46 is recognized as a hypodiploidy and in CNS literature as a polysomy. Whereas losses of chromosomes are defined as a hypodiploid cases. And in hematologic neoplasms, specifically in B-cell acute lymphoblastic leukemia and plasma cell neoplasms, these two groups have a very distinct outcome, with hyperdiploidy being a better prognostic marker and hypodiploidy a marker of a poor prognosis and high relapse rate. So we applied the copy number chromosomal microarray in meningioma, which is very powerful because in addition to copy number probes, it also applies genotypable probes. So it helps to recognize not only normal cases for each chromosome. You can see the plot on this diagram but also cases with losses, with gains of chromosomes, with copy neutral loss of heterozygosity, tetraploidy, and so on and so forth. So we analyzed 500 meningiomas, and you can see that the plots for chromosomal losses are very distinct from those with chromosomal gains. And this is a distribution of all the data on log2 plot, with the plot for chromosome 2 dipping down, so that clearly would be a loss, as well as loss of this chromosome and this. Whereas for gain, the elevation of the plot above the normal would indicate that there is a whole chromosome gain, and in this case it would be gain of 2 copies of chromosome 5. And not only, of course, the whole chromosomal gains and losses are detectable by microarray, but also segmental. But we just grouped the cases based on polysomy and hypodiploidy, and showed that roughly a quarter of cases have hypodiploidy with losses of chromosomes, and almost 10% had hyperdiploidy of polysomy. When we looked at the frequencies of distribution of chromosomes with gains and losses, the diagrams for both groups revealed a very interesting pattern. So first of all, you can see that polysomal group with predominantly gains of chromosomes highlighted in this peach color do have very, very low rate of some losses as well. And not only loss of chromosome 22, which is very recurrent in meningioma, and meningiomas with only loss of chromosome 22 recognized as a benign subgroup. But also losses on chromosome 1, it's almost invisible, 7, 8, 10, 14, and 19, but mostly it's the peaks of gains of chromosomes with a peak at chromosome 5, 12, 20, whereas hypodiploid group with losses of chromosomes, aside of loss of chromosome 22, which is quite expected, have very frequent losses of chromosome 10, 14, and 18, and very infrequent gains of chromosomes. And if you can see, the distribution's almost flipped in an opposite ratio, making me think that very possible that the occurrence of aneuploid meningiomas happen as a result of abnormal chromosomal segregation, and then based on additional hits, either polysomal or hypodiploid group get a survival advantage and then become a predominant clone. Not surprising, the methylation profiles of both groups also showed a very interesting differential distribution of the probes and genes and patterns, and you can see that the borderline goes roughly here with almost opposite distribution of methylated and non-methylated probes, and the polysomal group is grouped on the left side, and hypodiploid group is mostly shown on the right side, confirming that polysomal and hypodiploid meningiomas belong to two distinct methylation classes. What about progression-free survival and overall survival? These groups show a very different dynamic. You can see that the hypodiploid group with losses has much worse progression-free survival and much worse overall survival compared to quite good overall survival of a polysomal group. And talking again about those additional second hits, third hits, what define either polysomal or hypodiploid group, When we looked at segmental losses on chromosomes 1p, 1q, and so on and so forth, not surprisingly, polysomal group, as you can see, has very low rate of additional hits. And the recognized high-risk marker, loss of 1p, is not predominant, and losses on other chromosomes is almost invisible. Whereas hypodiploid group has a very distinct pattern, right, of additional losses, and interestingly gain on chromosome 17q, with 1p being present in the majority of cases. So that supports that hypothesis that probably as an accumulation of second hits, hypodiploid group becomes quite complex, and that defines poor prognosis. That observation of 1p loss was very interesting and made us think for a minute that maybe that's why the group has such a poor prognosis, and maybe it's even the same methylation class of meningioma as 1p deleted. To check that, we collected also a cohort of meningiomas with only 1p loss, as well as some segmental losses, however, with no whole chromosomal changes. And as you can see, indeed, the progression-free survival of hypodiploid cases in bright red are very comparable to the 1p deleted cases, as well as overall survival. Whereas polysomal group in blue color groups for both progression-free survival and overall survival with a benign meningiomas with no copy number changes, or only with a loss of chromosome 22. So that confirms that these two groups are very distinct, not only by methylation profiles, but also by methylation profiles. But now we were curious just to see, based on almost identical survival curves, if 1p deleted meningiomas and our hypodiploid meningiomas, which have very frequently loss of 1p, are the same. And what's interesting, you can see that that's not the case, and the hypodiploid meningiomas are grouped on this side of the plot, whereas these cases have meningiomas with predominantly just 1p deletions, with almost opposite profiles for differentially methylated probes. So that means that no hypodiploid meningioma is very different from just 1p deleted meningiomas, and all those additional losses of chromosomes contribute to the overall methylation profile. So in summary, we can conclude that aneuploidy is quite common in meningioma, with roughly a third of the cases showing either hyperdiploid or hypodiploid karyotype. And with hyperdiploid or polysomal and hypodiploid meningiomas have distinct methylation profiles, a very peculiar non-random pattern of chromosomal gains and losses, and very different clinical outcomes, with polysomal meningiomas grouping in a low risk category and hypodiploid meningiomas being a high risk meningioma tumors. And these combined differences of chromosomal gains, losses, differential methylation pattern raise possibility that hypodiploid and polysomal meningioma represent distinct groups with very different outcomes, and that can be used as a predictive marker of recurrence rate and the need of treatment. And to illustrate that, I would like just to show very quickly in the remaining few minutes a real clinical case which we analyzed after development of methylation-based classifiers. As you can see, this plot demonstrate the tumors with grade 1, grade 2, and grade 3 risk prediction. This is a meningioma case with a very typical presentation. Patient was admitted with a seizure and abnormal MRI, which revealed the lesion, a dural-based lesion, and patient undergone total tumor resection. And when pathology department did a whole profiling of this meningioma, it was identified that with no brain invasion, with very scattered areas of all these additional morphological markers, and only brisk mitotic activity with focal areas with 7 figures. That the tumor was graded as a grade 2 meningioma of intermediate prognosis, and chromosomal microarray did not identify CDKN2A or B deletion, did not identify loss of 1p. As you can see, it identified only loss of chromosomes 14, 22, and Y, which qualifies it as a hypodiploid now. And when we also plotted this case on our predicting classifier map for recurrence, you can see that it does not group as a grade 2 meningioma. And this complex pattern of losses pushes it towards a higher grade, and not surprisingly, patient recurred very fast, only 3 months after tumor resection. His tumor started growing back. With that, I would like to acknowledge my team, both clinical labs who helped with data collection, and bioinformatics team who helped with the analysis of data. And thank you very much for your attention.